I hope you guys can see me as well, right? Okay. So Fawzia and Kavya, all right. Two candidates so far. Asma, Parveen, Manahil. Yes, Manahil. Yes, that's great. Okay, okay, that's great. So we have couple of candidates. So I think we will. What do you think, Shefali? We will. I mean, just have a overlook of the overview of MRCOG Part 3, the domains and the questions, and how do we go about the preparation and all, and then we will talk about our stations. What do you think? Hello. Okay. Mm-hmm. Shefali, are you there? Okay, fine. So let me just start this, the overview of part three. I hope by now everybody has some kind of idea what exactly the part three is. I mean, how we go about the preparation and everything. We know the syllabus and we know, the preparation as well. So we will just quickly go through. I will just, lots of exam going candidates here in 10 days. All right, all right, all right, Krishna. So that's very great. So we will just quickly go through. Please start the cases. Okay, no problem. We will start. So I will let me just quickly go through the domains and everything, and then obviously we will go through the cases as well. Okay, so quickly, we do have the understanding of the exam part 3 as well, that we do have total 14 stations, and we do have 2 minutes time for the initial reading time, and then we do have, but in the online we will be having 2.5 minutes. Okay, so that is going to be the initial reading time, then 10 minutes is going to be inside the cubicle, usually 5 to 6 hours structured discussion, and the rest are with role players, and out of them 4 are with lay examiners. And the lay examiners, whenever you see the couple of the people inside the cubicle, so always imagine and remember that this is going to be the highest exam, the marks carrying station. So some of the station can be linked station as well, but this is, I mean, not very usual in every station. There is no rest station, there is no break, almost total of 168 minutes, and then it's going to be over. So obviously this was used to be the physical exam, but in this era when we are dealing with the online, so the online exam is going to be like this, obviously, but you are going to be in the virtual world. Okay, so you will be having 3 type of tasks: simulated patient task with lay examiner, structured discussion task with only one examiner, and simulated patient task only with one examiner. So in the online exam, obviously everything is going to be online, like we are seeing each other. Okay, so this is going to be kind of virtual computer based exam. So this is going to be on Osler system, and I hope by far everybody knows what exactly the Osler system is and how the thing goes. And probably RCOG is the sending emails to all candidates about the Osler system as well. Okay, so the candidates and the role players, structured discussion, examiner interaction will all take place using video conferencing via online application with the remote invigilation. Okay, so everything will be online. You will be seeing role players, you will be seeing examiners, you will be seeing yourself as well somehow. Okay, so this is going to be like, I mean, clearly video conferencing. All you need is strong internet, 1 or 2 internet connections should be there, and your system should be very good, and the data speed should be very the accurate at that time. There should not be any kind of break. Always remember, okay, everybody, you should take this into account. There should not be any internet break, because if there is an internet break, if you rejoin, then certainly you can lose the time as well. So this is very important. So domains, we know that we have information gathering, communication can be with colleague, communication with the patients and relatives, then applied clinical knowledge and patient safety. So these 5 domains are very much important, because the somehow you have to do you have to fulfill almost all these domains in every station there is. So yes, for there is going to be 0 if you don't fulfill the any domain. 0 marks, 1 is going to be the borderline, and 2 is going to be the clear pass. So yes, you have to at least be between borderline and the clear pass to pass almost all stations. Every station has, the equal marks, and there is not going to be like, this station carry high marks, this station carry less marks. Okay. So stations, like, I have told you earlier that 3 people in the cubicle, it means the 1 examiner, 1 role player, and 1 you. And if you see the 4 people, then that's going to be the lay examiner. Look confident. This is very important for real exam. Okay. Appear as a safe doctor. Be logical, and you should be organized as well. You should be sympathetic and empathetic as well. But it doesn't mean that if patient starts crying, if role player is, the starts crying, so you start crying yourself as well. Okay. So you just have to be very, the kind of kind and composed at all times. Be patient and active listener. Okay. You have to be active listener, and this should be the basic, the concept behind simulated patient task. Because once you don't listen to the, the role player, sometimes if you are, the going here and there into the task, and if you don't see the, the role player cues, you may miss some important information in the task. So it is very much important to listen to the role player. Sometimes they can guide you, and they do. Okay, they do guide you, they do give you cues if you are, going here and there. Use simple and understandable language in polite tone. At all times, you need to be very good and understandable. Change your character and be embedded in the role of a doctor in any specialty at the time of a station. Because there are going to be plenty of station, obviously. Some can be breaking bad news, some can be, the kind of happy station, some can be, the where you have to do a lot of communication, you have to do a lot of talk. So obviously, after like every 10 to 12 minutes, you have to embed into the character of the next, the doctor. So be ready. Reasons to fail part 3. This is also equally very important. If somebody is using too many jargons, if somebody is relying on courses or material gathered from here and there. Okay. So this is the basic, the misconcept of this exam. That if I get, so many videos, if I get so many audios from here and there, so this is going to pass me. No. You are only going to pass when you rehearse a lot, when you speak a lot, when you study properly, because your applied clinical knowledge will be tested at all times. So you need to have a persistent and consistent daily practice, even if it is not daily. So it should be like, on regular basis, I must say. Okay. So believing in the myth that knowledge will not be tested, and believing in the myth that it is a pure knowledge test and just the communication skills. Because these days, I am taking, the candidates with me, and many of the candidates are so good in communication, but they fail to do structured discussion tasks. So prepare both tasks very well, because you will be having, the both kind of task, and you will be judged on both tasks. This is not like, always that you only have to speak well, and you don't know what exactly the applied clinical knowledge is. Not believing in yourself. Please stay strong. Be confident at all times. Okay, believe in yourself. You have come this far. It means this is the last step which is going to make you the member of Royal College. Okay, so believe in yourself. Look confident but not overconfident. So overconfidence and even underconfidence should not be there. At all times you need to be very composed. Okay, so be composed at all times. So this is the reason why many candidates do fail this exam. What exactly is part 3? What exactly is part 3? We know it is the combination of knowledge blended with your communication skills, but applied clinical knowledge. Applied clinical knowledge means that you have to utter the words which are important only to that particular station. You don't have to, narrate 60 pages, 80 pages guidelines in one station. You have to be very specific. Okay. For the structured discussion, I must say to the candidates who are going for this exam, please listen to the examiner. Okay, listen to the examiner, try listening to the examiner. That is very important. What I see is that, candidate enter into the cubicle and they just start talking. No, if it is written outside that, this station will have 3 or 4, the questions, examiner is going to ask you 4 or 5 or whatever questions. So keep it in your mind that you have to divide your time into, accordingly. If it is 4 questions, then 2.5 minutes each. If it is 5 questions, 2 questions each. And remember, structured discussion is a kind of, the evolving discussion. It is not like random. So if you have been asked in first question, what is your diagnosis, for example, for everything, anything. So then the second question can be, what are the differentials for it? The third question can be, what is the initial management? Then so on and so on. Okay, so keep this thing in your mind, that don't pour into your complete knowledge. We know, examiner, everybody knows that you are well read, but this is how you need to be structured. Okay, you need to be structured at all times. All right, so use your applied clinical knowledge, listen to the examiner, and just listen what examiner has to ask you, listen to him attentively, and then just sit quietly. If you have finished your first question, wait for second question, and in the last question you can add your own points. You cannot go back from fifth question to first, and first question to the second and third, and so on. You are not doing the structured discussion. Then it needs to be structured discussion. Okay. Okay, domains. Dr. Shefali, I would like to take your input into this information gathering. Just in few words, if you could summarize.
Hi, thank you, Zeb. I think you've summarized it really well. And I just wanted to say to the candidates, like, active listening is something which is very, very important. Even with information gathering, when we talk about it, yes, you should have a template already in your brain that how you're going to take a structured history. And like what I see is that sometimes, you read the station and you feel like, oh, this is how I've prepared and this is what I need to ask all these questions. No, that's not how you should approach the station. Sometimes you have to read in between the lines. When you get those 2 minutes, I want everybody to, focus on it and just see what they're asking you in the station. Because I feel like sometimes we waste a lot of times just taking the history itself, and then, you struggle to finish the station. So information gathering is more about, you take a brief but a detailed history, and in my opinion, you should never spend more than, I would say, 1.5, 2 minutes should be the maximum that you should spend on information gathering. And then, examination, if it's given like Dr. Zeb has explained in her slide, or you have to ask them, you always have to obviously take the consent of the patient before you want to examine and talk about the investigation. So information gathering, I would say, should not take more than 2 minutes. And that's where practice makes a huge, huge difference.
Yes, exactly. So in history, I will, take this opportunity to just talk about this history, that if everything, almost half of the information is given in the task. So don't spend a lot of time into, the taking history according to your set templates. This is really going to consume a lot of time. This is really going to put you in a lot of trouble. So what candidates do is that, they do try to rephrase the question as it is when they enter into the cubicle, that I understand that, this. Don't read the question as such. Okay. Either you have to rephrase it, or either you have to gather the important positive, information from that, and then you have to, talk about it. All right. And apart from that, please don't examine every patient there is. Don't examine unless it is specified that, if you say something, if you utter the word examination, then examination will be provided to you. If it is not necessary, please don't do unnecessary examination to every the patient, and please do leave that chaperone at all times. Unless it is needed, then do take the examination and do take chaperone. Okay, please don't try to be so monotonous in each and every case, because I do see, the one set template. I would like to examine you in the presence of chaperone, then I would like to do some investigations if needed, and then I will give the, management options, and then I will give you some patient information leaflet, and in the end, and this and that. That look so monotonous, and that looks so, the kind of set template. You need to be very original. You need to be yourself in exam. Okay. So please be, the kind of very, the spontaneous. It should not be very robotic, that you have rehearsed, the one station a lot priorly, and now you are here to just, pour out that, the robotic knowledge in front of examiner or role player. So be natural. Okay, be yourself. So investigation, if the, the really, that is the demand of station, then you have to talk, and then you have to say something about investigations as well. Then applied clinical knowledge. So we have said earlier that we do have set, the standards of applied clinical knowledge. We do have green top guidelines, nice guidelines, top articles, strategy cases as well. So if you guys have time, so please go through some of the important modules of strategy cases, because these are very much important. And then communication skills, this is also very important. You need to be active listener first. Okay, so active listening is very much important. Unless you listen to somebody, you are not going to get the idea what exactly the station is, what exactly the you are going to talk. Then second is that you need to be professional at all times and objective. Just, I mean, be at the same station you are talking about. Don't go here and there. Don't bring extra knowledge. This is not going to give you extra marks. Rather, it's going to cost you your time. Remember, even 1 second, 10 seconds, 30 seconds are very much precious and important in this exam. Third communication skill is always think before you say anything. Fourth is in the breaking bad news. Breaking bad news should be like, I mean, kind of that how you are going to discuss the seriousness of a situation. And I'm sure all of you knows that how to break the bad news and what are the set the kind of warning shots, first shots, second and third, and then so on, and then how you go about. And there are two schools of thoughts for the breaking bad news. I hope Shefali will give you the better idea, but for me as an examiner, what I see is that there are always two schools of thought. Either you break the bad news first and then take the history, or either you take the small, the targeted history, but don't just stress out the woman. If she is asking you again and again, okay, can you please tell me what exactly is in the, this report, in the histopathology report or anything, biopsy report. So please listen to her, take her cues. If she is asking you again and again, so don't stress her out. So it always depends upon that, what the, the school of thought are you comfortable with. If you are comfortable with taking first the targeted history and then breaking the news, it's up to you. If you want to break the news first and then you want to go ahead with the consultation, it's up to you again. There is no hard and fast rule. What do you think, Shefali, for this? Hello? Okay, so she will come because just I mean, few hours ago I had a call from a very dear friend. So she was very upset regarding this breaking bad news thing. So we always say that there are two schools of thought. There is no set template. There is no set, the thing that how you are going to talk and how you are going to give the bad news to the woman. But always remember, at all times you don't have to stress out the woman. Okay, so if she's asking you again and again, again and again and again, so don't just think in your mind that okay, no, 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 I have to take history first and then I have to break the bad news. No, if you are comfortable with this, you can go ahead with that. If you are comfortable with, I mean, taking the targeted, remember the word, if in station, if it is written, I mean, take focused or take targeted history. So please do take targeted history. Don't go to the 3 pages of your set templates. Okay. So be extremely careful. Communication with patients and relatives, an important exam station scenario. Oftenly it comes, and usually it is angry patient, angry husband, angry relative, the angry mother. There are, the certain, that there are various stations. In fact, the one important, the recurring topic is that angry husband after post hysterectomy debrief. Okay, for the woman, there can be post, the operative debrief of the pulmonary embolism. There can be postpartum debrief of the IUFT as well. Okay, sepsis as well. If she is in ICU or if she is, she has lost her life or whatever. There can be anything. So you need to learn that how to diffuse the anger as well. So how to diffuse the anger? The normal, what you do is that, first we have to listen to somebody who is speaking. So obviously that is going to diffuse the half of the anger. Then, go, the step by step, and then just, ask about the concern and then kill that concern there and then, move forward. Okay. So angry stations, this is going to be also very challenging if at all it comes in exam. So just remember that you have to listen to the the person who is talking to you, and then I think you can deal with it, because after like a lot of and plenty of the discussion, so candidate is in good position to talk and to deal with every situation there is. So just learn that how you are going to diffuse the situation. Okay. Responsibilities as a candidate, you should understand what are you at this level. For example, if it is written in outside that you are ST3 candidate, you are ST1 candidate, and you are doing this. So you should understand what are your responsibilities, okay, as a candidate. So this is very much important. And then, where to stop, where to involve. That is also very much important. Even though, many of us overseas candidate are working consultant in their own respective countries, but for, the MRCOG, you are still, the student. So just, remember, just think out of the box. Okay. Just think and imagine that you are standing at NHS in the hospital and you are just ST3, ST4, the at whatever level. So you have to fulfill the responsibility of that, the training level. All right. So don't forget to involve multidisciplinary team approach. If you think the station is all about the management, in which you have to involve plenty of specialities, so do, try to be very vigilant. And then yes, if it is a referral letter, don't forget to write back to the referral, whoever has referred, GP or midwife. This is going to touch your communication with colleagues as well, and also patient safety, because you know that GPs are cornerstone at NHS. Every healthcare, the kind of you can say primary screening will be done at GP level, and then the patient will be sent to secondary or tertiary, the level. All right. So it is very much important. So do write back to your midwife or the GP if it is written in the station outside the cubicle. So patient safety is also very important. Name and age, this is very important. It means that in previous scenario, you were dealing with some Martha, and in the next station, you are dealing with Mary. So don't call Mary Martha again and again and again. If at all you remember at any point, so please excuse yourself, or you can say that I'm sorry that, I'm sorry, Mary, okay? I'm sorry. So please accept it and apologize. There is no harm. All right. So living status is important, LMP, BMI is important, because BMI is very much important in certain things: smear history, contraception, medication, alcohol, smoking, drugs, history of allergy, proper referral. That is very much important as well. Then outside the cubicle, 2-minute time is also very crucial to all candidates who are going for exam. I'm sure you all know, but please don't make keys outside in the 2 minutes. Just read the question again and again. Okay, read the question again and again, so you are not missing even a tiny information outside the cubicle. So when you will go inside, your mind will be ready to perform in that station. Okay. So just the highlight in your, if you really want to write it down, so in the online system you will be given a window, and you can write it down. So obviously you have to type. So there should be a typing ability as well in the online system as well. So even if you think that you can't type, so just keep important things into your mind, that okay, her name is this, her age is this, and she came with this presenting complaint. So like every history, like any patient who is coming to us in our hospital, so what we do take history, okay, and then we do examination, then we run some investigation, and then obviously we do try to manage it as well. So similarly you have to do in this, in all these stations as well. They are not like, I mean, kind of different, or the out of the world. Obviously we all have to rehearse, we all have to talk, just in a way that we are working at NHS, and we are that we have to behave like an NHS trainee as well. So note down if you really want to, and formulate in your mind that how you're going to start the station, because sometimes starting the station is also very difficult. It can take up to 30-40 seconds and 50 seconds as well. So do rehearse it too. Read question again and again, so not to miss anything inside the cubicle. Don't start making keys. I am strictly against making keys outside the cubicle, because in 2 minutes time, it is like, I mean, kind of impossible task that you will write down, you will make keys, you will be like, okay, I will talk this, I will talk about this, I will write. So what you will do, either you will write, or either you will speak, or either you will train your mind that, okay, I have to start this way and I have to speak, this thing. So please be extremely careful. Inside the cubicle, look confident, enter into the cubicle. So this is going to be online. So, I mean, the same likewise that, when you will enter into the next room, so be confident. Whatever the previous question was, forget about it. Now you have to deal with this station. Okay. So just, stay calm, stay focused. If the previous question was very bad, or if the previous question was very good, don't try to be, like, I mean, kind of overwhelmed if it was good, and don't try to be depressed, and don't look depressed as well, that it was a bad station, so it is going to affect your current performance in this station as well. All right. So stay calm, because somehow what can happen is that if you don't do good, or if you don't do good in the previous station, you can do the excellent in this station. So just stay calm, stay focused, just try to take few seconds. If you think that you still need some kind of time, so you can ask the examiner or role player, can I just take 30 minutes, 30 seconds? Okay, can I just, look at the question? So they are not going to say no to you, because these 10 minutes are for you exclusively. So this is your job, how you are going to utilize these 10 minutes. All right, but don't spend, the extra time as well. So sit comfortably, the behave comfortably. If you have finished your session before time, so just, sit comfortably, even in the online. Don't look here, don't look there, don't look up, don't look down. Just, the sit as, the you are sitting while doing the session as well. So be extremely, the kind of natural, look natural. Okay. And preparation, like, everybody knows, organize yourself. And we don't know how somebody is going into his or her life. So, you have to organize yourself according to your own circumstances. Okay. Make a comprehensive schedule according to your job, according to your household responsibilities, and look for a good study buddy. If you don't find a good study buddy, rehearse with yourself. There is no harm. Okay. So don't look, and don't, please, this can be the kind of trial, and the some kind of, like we say in pessary insertion, that can be the matter of, the trial and trial. So likewise for the study buddy, if you're not comfortable with somebody, okay, you can just excuse yourself. If the time zone doesn't match, you can excuse yourself. Okay. And please don't study with somebody who is going to undermine you, or who is going to make you inferior at all time, make you feel inferior. Okay. Don't study with that person, because that is not going to be the good study buddy for you. That is not going to be the sincere person. So you can always choose anyone you are comfortable with, your time zone matches, and you think that you can study well. Okay. So make templates if you can, or write down your important points, wherever you want to. Make your own notes. Okay. It's not like that you are making, the sheets and sheets of, the one station. You can just make, the important templates, or the flashcards or something. So do all available stations in books, and do revise them later as well. So at least revision is a must thing for this, because it's not like that, you are not well read. Everybody knows you are well read. You have passed part two. It means you have basic knowledge. But for the part three, you have to refreshen that knowledge as well. Because in the part three, you have to speak in patient's language in some stations. You have to speak in the the doctor's language in, structured discussion task as well. So it is very much important to revise. Okay. So revise your own syllabus, revise your own, the points as well. That is going to help you a lot. So, gather the curriculum. So we all know, the same modules, what we study for the part two, the same modules are going to be tested in part three as well. There is no difference. All you have to do is that, in part two, we were reading guidelines. For the part three, you have to read the same patient information leaflets. The knowledge is going to be same, but it is going to be in the patient friendly language. Some of the patient information leaflets are not available on Royal College website, so you can always Google. You can always Google. You can always go to NHS, the PIL, any of the hospital PIL. So use, and definitely, it will come with the practice. It will come with the, the knowledge as well, that how you have to Google things. So learn how to Google things as well. This is also equally important in this preparation. Okay. So once you will know that you have to speak, you have to behave, how you have to, the prepare for this exam, your life is going to be very easy. For the exam candidates who are going for this exam, all you have to do is, in the last 10 days, or no, whatever the days are left for you, please organize yourself. Okay. Don't go here and there. Don't look here and there for, the set templates or anything. You have studied a lot. You have studied enough. Now this is the high time when you will revise for yourself, when you will study for yourself. Okay. So don't just waste your time by taking, so many, the activities, by taking part in so many activities here and there. Just, restrict yourself to your own, the timetable and the schedule. So books, we already have, this is recommended, and I highly recommend this book for the beginners, for the starters. Okay. So this part 3 MRCOG, Your Essential Revision Guide by Lisa Joel. This is such a beautiful book that it will give you a very good start in the beginning. Then you have to do the task for the part 3 from Clinical Assessment by Sambit Mukhopadhyay. So this is also a very good book. Okay, Oxford Specialty Training. So it has got almost 14 plus 4, 18 stations. it has got almost 89 stations, it has got almost 50 stations. So altogether, how many stations are there? 100 plus. 100 plus mean it's not only stations, it means you are covering 100 topics. Okay, so if you are rehearsing with yourself or with your study partner, it means you are revising 100 plus questions as well. Plus this book is very much important. It has got, I think, 2 circuits and 6 rest of the stations, so 28 and 6 like 32. And this is also very beautiful book. Okay, it has also got, the station. So all you have to do is revise and practice, in fact. Okay, so do as many stations as possible, just practice. Okay, so I think 100 stations are more than enough to prepare for this exam. All right, so all you have to do is that practice them. If you are with your friend or study buddy, one time she can be the role player, other time you can be the role player, so this way you can rehearse, but be very neutral and very sincere in the giving the the judgment or the markings as well. Okay, but again, remember, don't try to humiliate, don't try to mistreat, or don't try to make anybody inferior, because this is very the kind of crucial time where everybody is at edge. Okay, everybody is at at the time where somebody can feel anything. So don't try to ruin somebody's mental health as well, that is equally important. Okay, while we are preparing for this exam, how much time is enough? This is very important question. So I personally believe that if you have just passed your exam part 2, and if you are getting the seat, so please don't delay. Okay, go for it, because these days everything is so cumbersome, everything is so the kind of difficult, getting the seat, then preparing for this exam, and then obviously that how you prepare, that is also very important, that in what circumstances, what condition are you in, and what phase of life you are going through, that is also very important. But at least for a candidate who is aiming for this part 3, 4 to 5 months dedicated and sincere study is enough. Okay, so don't spend a lot of years the preparing for this. If you get a chance, I know the COVID has put some kind of extra strain to everybody, likewise for this exam as well. So yes, people are waiting. So I think inshallah by like 2022 we will be having the good slots and the good the exams. So February, I guess we will be having another extra the exam center Egypt. So it is going to be complete online again. So I think we will have the quite fair chances for every candidate. So be prepared. February is not like kind of ages away. This is hardly November, December, January, and then February. So prepare, start preparing if you guys are aiming for February exam. Okay. So yes, it was a quick overview. I'm sorry for the people who were waiting for the stations, but this we had to do. Okay. For the last 10 days, dear Salma, for the last 10 days, okay. For the last 10 days, first of all, restrict yourself, restrict your activities. Okay, make your own, the kind of schedule. For example, when I was preparing for my exam, so I gave 1 day to each module. Okay, I gave 1 day to each module. For example, I have to revise today. For example, I have to revise this sexual and reproductive health. So because I already know what are the topics, so what I did was I just tried to revise the topics properly, so I am not missing the any information. And because I was off work at that time, so in the morning time I was revising with myself, and in the evening time I was rehearsing with my the study partner. So this you can do as well if you are comfortable, and if you think that your stress level is so high you can't even talk to anybody, fair enough, there is no hard and fast rule. Okay, so but revise, revision is must before exam. Okay, revision of clinical the knowledge, revision of the syllabus, revision of your own points if you have made any, that is very much important as well. All right. Okay, so I'm sorry
Hello,
I have been
Dr.
speaking a
Zaib.
lot. Yes, yes, yes.
I have one question.
Mhm.
Is the task available inside the cubicle?
Yes, yes, it is, it is.
And suppose if the task has 2-3 pages, can we
Mhm.
look inside the cubicle in the task?
Easily, easily. See, look, sweetheart,
Okay.
let me show you that how it works. For example, I'm going to draw a rough, the screen for you here. This is the computer, your screen, your computer screen. Okay. So this is going to be, you can see examiner, role player. If it is lay examiner, then you can see him as well. In here, in this window, you will be seeing question at all times, and there is going to be cursor. There you can, look back and forth. This is your station. This is your time, 10 minutes. Okay. So you can see station, at all times. Even you can maximize it, you can minimize it. It's all up to you. All
Okay.
right.
And in offline, yes, thank you, Dr. Zeba. And in offline exam, can it happen in similar way? We can look task inside the cubicle.
Yes, at all times. Because, for example, this is my table at the moment, and the task will be pasted on the table. Okay, and I will be given a notepad and a pencil, and that will be given from the RCOG. Okay, so at all times I can write down on my the notebook, and at all times I can even look at the table as well for the task.
Okay, okay. Thank you very much, Dr. Zeba.
Okay, okay, sweetheart. Okay, okay. Any other questions before we move on? No question? Okay, over to you, Shefali. So this is going to be your task.
Perfect. Thank you very much, Seb. That was very good. I think you've pretty much summarized everything.
I
And
did. Would you like to add something if I missed something?
to be honest, I can't think of anything that you
Thank you
out of.
so much.
But I'm more than happy if somebody has to ask me any
Exactly.
questions before we start with anything.
Thank you so
Sorry,
much.
can I ask one question?
Yes, why not? Please.
With regards to the new guidelines which come up, like the diabetic guideline and some new SIPs that are coming up in the last month or maybe 3-4 months, do we need to go through them as well in case, or
Yes.
is it?
Diabetes is an important topic. You can't leave it. Okay. But for scientific impact paper, there was, I think, one that was cryopreservation, I believe. Okay. So that is not an important topic. You don't have to go through. But diabetes is an important topic. You can't leave a single thing out of diabetes. Okay. You can't leave anything from hypertension, colposcopy, the NHS-CP guideline. That is very much important. Okay.
No, what I meant was the latest guideline. Means
To do
obviously we will read the guideline, but something which has come up, say, within a month.
within a month. If it is just like, few days ago, so you don't have to do that. I think day before yesterday, amniocentesis guideline was released and one scientific impact paper was released, but I don't think that is very significant and important. And even there are no, the many changes. Okay. I have gone through that. There are no, the kind of big changes that are going to affect the exam.
Okay, thank you.
Okay, okay. But don't leave diabetes. Diabetes is an important subject. Okay. BBN and precancerous lesion. Should we do or not? You have to do each and everything, Fatin. You can't leave a single topic. Okay. These topics are very much important. You can't leave them.
Dr. Zaib, I mean, in breaking bad news, in precancerous lesion like in sclerosis, like VIN, when we are explaining the diagnosis to the patient, should we do a complete breaking bad news, or
Are they
just
bad news? Are they cancerous?
VIN, like
Is it
VIN,
cancer?
like ovarian cyst, endometrial hyperplasia, all this
No.
condition?
If it is endometrial hyperplasia with atypia or atypical hyperplasia, then yes, that is going to be kind of breaking bad news, because all you have to offer is hysterectomy as a treatment option, isn't it? But if it is lichen sclerosis is not cancer. So why do you have to do the breaking bad news? Likewise, VIN, vulval intraepithelial neoplasia, although it is the kind of vulval intraepithelial neoplasia, but it is also precancerous. It is not cancer. Okay, so what you have, even you can be little polite and you can ask, we will do VIN, so please don't we will do VIN today. Okay.
Yeah, because usually when you say do the breaking bad news, the role player can shout and say, "Oh, I have a cancer. Oh, I will die." So again, you need to say it is not a cancer, but we just have a little concern. So some people say that don't do a complete breaking bad news, but just say we have a concern regarding your result.
Yes, exactly. This is what you have to say. If it is precancerous, so obviously you can't do all steps of the cancer breaking bad news altogether. Okay, you need to be little polite, you need to be little concerning. You can say that I have some news that can be disturbing for you. Okay, I have some news that was not, the kind of expected. Okay, so this way you can start your consultation. What do you think, Shefali?
Yes, I just wanted to add, I think
Hmm.
with the Breaking Bad news, I think candidates do have a misconception, sometimes like you mentioned, about lichen sclerosis or VIN. So like Dr. Zeb explained, I would go about it by saying that, your results are not what I expected, but,
Exactly.
you still need to kind of reassure them and tell them that it's not cancer.
Hmm.
So I think it's about the choice of words that we use that makes a huge difference. So that's where, practice comes again.
Hmm.
Because
Hmm.
not every station you can approach in the same way.
Exactly. So it's not like that you are going to give, the all warning shots of Breaking Bad news. Even the Paget's disease, it is also precancerous. It is not cancer, yeah. So if it is cancer, for example, if it is stage 2 cervical cancer, if it is the stage 2 endometrial cancer or ovarian cancer, anything, any cancers, then cancer is, yes, it is a bad news. Then you have to break the bad news. Then you will go, step by step. Okay, then you will give her time. Then you will give her choice as well. Okay, that how you want me to go ahead. You want me to stop here, or you want me to explain, the further management as well. So like Dr. Shefali said, that it is all going to be, the choice of words, how you are going to deal with it. But for the precancerous, I personally believe you don't have to fulfill the Breaking Bad news criteria. Okay, we will do one case today, so don't worry. So we will try to understand, how we are going to talk about it. Okay. Okay, so we
Okay, thank
need
you.
2 volunteers. Who wants to come? One is going to present with Dr. Shefali and the other is going to present with me. So please.
Can I do?
Oh yeah, sure, why not? Okay, Shefali, over to you.
Thank you. Thanks, Zeb. Right.
Okay, fine.
So can I have the name of the person who's willing to present, please?
I am Fatin.
Fatin. Perfect.
Okay,
Right.
so let me show you the case and let me start the timer as well for you. 2 minutes time, okay? Okay, start. Okay, are you ready?
Yeah, I'm ready.
Okay, fine.
Hello, I'm Dr. Sayed, one of the hello, I'm Dr. Sayed, one of the doctor in the clinic today. May I confirm your name and age, please?
Yeah, my name is Anna and I'm 15 years old.
Hello, Anna. How do you feel today?
Okay.
Yeah. So, Anna, I understand that you have done some scan and you are here today to discuss this scan. Is this correct?
Yes.
Yeah. So, Anna, are you in the school?
Yes, I am.
Yeah. How is everything in the school?
Yeah, it's okay. My friends don't talk to me much, but yeah, it's okay.
May I ask you why you do feel that?
I don't know, doctor.
Okay, Anna, as this first time to meet you today, I would like to ask you a few questions to know more about you, and then we will discuss the result. And I would like to assure you that whatever we will discuss today will be confidential between me and you. Is this okay with you?
Yeah.
Yeah, and I will provide you with whatever help and support you would like to have. Okay?
Okay.
Okay, so Anna, can you tell me more about your pregnancy? How is going so far?
Yeah, it's okay, doctor. I mean, I don't know. I don't speak to my boyfriend anymore. I wasn't planning on it, but
So,
it seems okay now.
so are you happy to continue with this pregnancy?
Yeah.
So may I ask you about your partner? Is he your classmate?
Well, he's in the prison now, so I have no contact with him.
So how old is he?
He's 16.
So have you been feeling safe with him?
I don't see him now, doctor.
Okay, I can see. So regarding this pregnancy, do you have any problem, any pain, any bleeding, any discharge?
No.
Okay, so is this your first pregnancy?
Yes.
So are you currently in any other relationship?
No.
So do you have any health issue at all?
No.
And when was your last period?
I guess 26 weeks ago.
Have you ever been diagnosed with any sexually shared infection?
Not that I'm aware of.
So do you smoke or drink alcohol?
No.
Pardon me to ask, any recreational drug?
No.
And with whom do you live, Anna?
I'm living with my parents right now.
Do you feel supported at home?
Well, my dad is very upset with me, but he doesn't talk to me. But yeah, my mom is okay.
Okay, so last few weeks, did you bothered by feeling low or depressed or loss of interest?
No, it's fine, doctor.
Okay, so I'm just trying to assure you that whatever we will discuss here will be confidential, and we are here just to help you and support you whatever you are facing. So would you like to talk with me with any something that you are facing and make you unhappy or?
It's just, I feel I wasn't ready for this pregnancy, doctor. And my community midwife keeps forcing me to come for the appointments. I'm not interested in this pregnancy, but I've learned to live with it now.
So do you have any thought to terminate this pregnancy, or you want to continue with this pregnancy, or?
No, I don't want to terminate.
Okay, so we have some option for you. I will come to discuss this option with you in a couple of minutes. but I just wanted to discuss the result with you for the scan you have done. May I ask you why you did this scan?
My midwife forced me to come and get the scan.
Mm-hmm. Okay, so the scan show that you are now 25 weeks and the baby is okay and his weight is okay, he's having a normal growth, and the amount of water around the baby is okay as well. So the baby is really in a good condition. So as I see that you have some troubles with the midwife, would you like to continue your follow-up with midwife, or you wanted to come and continue your follow-up here in the hospital?
Yeah, I mean, it's just I can't miss classes too much, doctor.
Mm-hmm. Mm-hmm. So do you think that it will be okay that if you talk to the counselor, we have a lovely counselor here in the hospital that can talk to you and help you in your situation?
Yeah, that would be good.
Yeah, yes, yeah. Okay, I'll put you in touch with that. And also we have a specialized nurse with teenager pregnancies. So I think it will be valuable that to put you in touch with this nurse and just answering your question and help you in your pregnancy. Okay?
Okay.
So I can see that you are worried that you will not be able to take care of the baby. So we have option that if you would like to continue the pregnancy, you can continue. And after the giving birth, we can find adoption for the baby if you are comfortable with that.
Okay, I haven't thought about this, doctor, but it's good to know.
Yeah. So do you feel that you will be able to take care of the baby and support the baby?
I think my mother is a big help, doctor. She says that she will help me.
Yeah, okay. So can you tell me more about what bothered your dad with you? I can be supportive in this.
It's just my dad wasn't expecting me to be pregnant, you know. He wanted
Mm-hmm.
me to study and become something in life, but this was very unexpected for me as well.
Mm-hmm. Okay, if it's okay for you, I can next time invite your dad to our consultation and discuss this with him. Would that be okay for you?
Yeah, I think that might make a difference.
Mm-hmm. Yeah, okay, we can do that. So do you have any other thing that bother you?
What about my school, doctor? Can I still go to school?
Yeah, no problem to go for school. Do you have any problem at school?
It's just my friends keep laughing at me.
Why do you think they do that?
I don't know.
Okay, so you know, and bullying is not acceptable by any way, by any uh, from anybody. So I think we can be in touch with the school and help you in this issue because really it is not acceptable, and we can provide you support. Would that be okay for you?
Yeah, that would be good, doctor.
Mm-hmm. So any problem that you would like to discuss with me rather than this?
No,
Would you like to continue your follow-up with midwife or just to come for your follow-up in the hospital?
whatever you want me to do, doctor, I'm happy to follow up.
Okay, I can just inform my consultant, and from now your follow-up can be in the hospital, and a group of a team will be taking care of you, consisting of my consultant and the nurse specialized in teenager pregnancies, and also will involve your school in our follow-up for you. Okay.
Okay.
So, and then you will do the regular scans and the visits throughout the pregnancy, and we will call you back and discuss the labor for you and what option you would like in your labor. And also we'll provide you with support, whatever you need. And I will put you in touch with support group for teenager pregnancies. Okay?
Yeah, okay.
Okay. Any more question?
No.
Okay, thank you. Okay, I will provide you also with a useful patient information leaflet to know more about the pregnancy and the follow-up in the pregnancy.
Okay.
Okay, thank you. I felt I missed something, but I don't know what this.
Right. Sorry,
Yes,
Fatih,
fine.
I must have come across really rude, but you know, this is because we're dealing with a teenager, and this is how most teenagers behave. They're very limited in talking. So, but I would say that, you know, even with me being very like reluctant in sharing the information, you did really well on the station. You kept sympathizing with me. You kept saying that, you know, that the confidentiality, because what I feel sometimes we forget that we are dealing with a child. 15-year-old is a, you know, pretty much a child. And if you realize, her main worry was that her parents, like her dad is not talking to her, her friends are always laughing. So well done on the fact that, you know, you said that you can like kind of step in, speak to her father, and even speak to the school authorities and get involved with it. So I would say that you did really, really good on it. Starting like step by step with the feedback. I think introduction, very well done on that. You asked me about my school. You asked me that, you know, how I was feeling. The only thing is about the boyfriend. Like, I think you went in a bit of detail and you said that are you in another relationship? I told you that, you know, I wasn't ready for it. He's in prison. I don't speak to him. And you still asked a few questions. So like, you know, how Dr. Zeb was saying that be an active listener. So when she shared that information with you, I would suggest that we shouldn't, you know, explore that more, because she's told you about the boyfriend. She's told you he's in prison and I don't speak to him anymore. So that bit, like, you know, we could have just I think cut short on that. But apart from that, good that you spoke about if the parents were informed about it and that the father wasn't happy, but you know the mother is supportive. So you kind of established that she does feel safe at home and she does have some support at home. So well done on that. I think the question on last period, I would say avoid that because she's 26 weeks pregnant. So we could have, you know, kind of avoided that question, but it's fine. I think, again, Dr. Zeb did mention that we tend to follow the same template. And this is where I think she was trying to explain you that sometimes we have to change our things according to what the question is. Yeah. But regarding the advice, I think, again, you did really well in asking her whether, you know, she wanted to send the child for adoption, or did she feel that she can take care of the child. Well done on the fact that you spoke about that, you know, there's, so all this station was about was, you know, kind of reassuring this teenager that there's loads of support out there. You can speak to your community midwife, the health visitor, the social worker, the school nurse. So these are all the people that need to get involved in her care. So, you know, you were good in saying that I can put you in contact with all of them, right? Then if you didn't notice, she mentioned twice to you that can I still go to school? So what we do here, Fatin, is that we have special clinic for teenage pregnancies here, where the hospital provides that support to them and organizes their antenatal care accordingly. So, you know, you can ask her that, you know, you don't have to come, you don't have to miss school and come to the antenatal clinic. We'll make sure that, you know, we provide you with transport and we'll organize your antenatal appointments after you have finished school, because this girl obviously wants to continue with her studies and she doesn't want to miss out on the school part. So reassure her with that, you know, we can organize your appointments once you finish school. So you don't really have to miss out on your education. The government provides a lot of support to these girls. You have to talk about the housing, that, you know, if she needs any financial help with that, then the government would be willing to provide her that as well. And you can kind of choose saying that, you know, I can understand, Anna, that this is difficult for you, and trust me, there's a lot of support there, and we are more than happy and willing to support you in whatever help you need. So I think you kept on mentioning, which is very good, because this is what she wanted. And you agreed with her that she was happy to follow up with you. So, you know, you kind of built that trust in her. So I would say, all in all, well done on that, Fatin.
Thank you. Yeah, because I asked about the partner because I feel something there. There are maybe violence anywhere, problem anywhere. So I thought maybe he's in prison. I'm just bothering her anymore by any way. So that's why I tried to ask about where is the problem.
Yeah,
So,
no, that's fine. I mean, I completely agree. But I would say with teenagers, this is where, you know, the counseling becomes, because you you'll see that when you see these role players, they'll be more like, I was still giving you some information. Sometimes you'll find them completely quiet and they wouldn't talk to you at all. So I was trying to do that. And, you know, when they talk about boyfriends and partners, one, she said she wouldn't like it if you want to explore. But good part was that you asked me that, you know, is there something that you want to share? So that is the woolly question that you asked. So well done on that.
okay, thank you. Thank you very much.
Anything that Dr. Zaib you might want to add on to?
Okay, so that was very good. I think Fatin did a good job. Yeah.
Yeah, I agree. I think
Yeah.
she did very well on the
She did
station.
manage it very well. Yeah. Good, Fatin. Good, good, good. Very good. So keep practicing more, okay? And don't leave any loophole in your preparation. So you should be very good. And yes, non-judgmental approach. Yes, supportive. Yes, kind of, you know, the like Dr. Shefali said, that you have to say at all times, and you have to be reassuring as well. So let me just show you that what we did try to make. Dr. Shefali, can you please, you know, elaborate that
Yes.
what exactly?
So I think I've pretty much covered in my feedback, but communication, like, you know, your introduction should be well. Like Fatin, you asked that, you know, how was school, non-verbal skills, attentive listening is what I meant when you said that, you know, when we asked about the last menstrual period and, you know, where's your boyfriend? So a little bit more attentive listening. You were very, very empathetic in your approach. You did not use any medical jargon. So well done on that. You were pretty much like, you know, using layman language that she can understand. Then with the history, you did establish the age of the boyfriend and where he was, if the parents were aware. You asked about school, the rest of the medical social history. So I think you scored pretty much all the points on that one. Then urges her to inform the parents. So you did establish that, you know, the dad was not happy, the mom was supportive, but still, like, you were happy to invite the father for the next consultation, so that, you know, you can play your part as well. GP was something that you forgot, but I wouldn't give you a negative mark on that, because apart from that, you did establish your other concerns, and you kept on talking about confidentiality and consent. So well done on that as well. Advice clearly, and obviously you had a sympathetic approach about the options for pregnancy, whether she wanted to give it up for adoption or keeping the baby. I think you did talk about termination as well in this, Fatin. I think we can't terminate above 24 weeks. So that's something that you did mention. So, don't talk about termination once they're like 25, 26 weeks. Okay?
Yeah, I know, but I try to explore what is the problem.
Yeah, because once they're above 24 weeks, even on social grounds, you cannot terminate the pregnancy. So your options would be about adoption or keeping the baby really. Then
I was thinking that this teenager would like to harm herself. That's why I asked about termination.
yeah. So yeah, you did ask me that, you did ask me the really question that do you feel okay? Or do you feel depressed or anything? So I did say that, yeah, no, I'm okay. It's just my friends keep laughing at me. So that doesn't make her suicidal or depressed. So termination of pregnancy would still go out of question in that, okay? And option to talk with the community midwife health visitor, I think you mentioned pretty much everything, and safeguarding and social concerns. You did do the referral to the counselor as well. So well done on that again.
Yeah. Shefali, there is a question from a candidate, Amulya. She's asking that, can you please repeat the school going part of the pregnant teenagers? She's asking to repeat that part.
Sorry, Amulya, which part? School going part for teenagers, as in? That
I think
we have
she's
special
talking about the support, I believe.
Right. So I think we have that on our next slide, Zeb. If you can just put on the next slide.
School going part. I'm sorry, I forgot to add. Can you please,
Right. So with the school going part, Amulya, when we see these patients, so we do have special clinics in special antenatal clinics for teenage pregnancies, which can happen, you have to give them that reassurance that she doesn't have to miss school or she doesn't have to miss out on her education. And we can organize all her antenatal appointments after she's finished school. And the hospital even provides them with transport. And if they have any financial burdens, the hospital does take care of that as well. So you need to make a referral to the social services here, and they have a named midwife. So every hospital here has specialized midwife who deal with teenage pregnancies, and you put them in contact with them, and these community midwives are very good in organizing everything for these girls, because you can imagine these girls are at very high risk of going into depression or not supporting themselves adequately. So we make sure that we give them all that support, and you kind of reassure them that we'll put you in touch with the school nurse as well, and we'll make sure that you don't miss out on anything. Does that answer your question, Amulya?
is it clear to you, Amulya? Okay, fine.
Right, I have a question from Seema, which says that, do we have to mention the risk of teenage pregnancy? So in this station, I wouldn't particularly worry about that, Seema, because if you read, it clearly mentioned that you have to take the history and you have to do the counseling and advice, right? So I wouldn't go too much into the risk. All I would say is, like Fatin she kept on reassuring me, and she kept on building that confidence in me that, it's more about the support. So you need to tell her about all the support that's available and the referrals that you will make for her, which would be your, the community midwife, the safeguarding, the social services, the school nurse. So this is what this station was more about.
We have another question. Somebody is asking that, if she is 22 weeks and she wants termination and she is asking for termination today, so what do we have to say in that case?
Well, in that case, first of all, you'll say that I will have to speak to my consultant, because this is, again, remember that this exam is at an ST5 level, okay? And here, when we are talking about termination, you need to put your seniors. So you need to escalate it to your seniors. So if she does want termination on social grounds, yes, you can go ahead and offer that, but don't start talking about it when you have to say that I will have to escalate and organize another appointment. But say if the station says that, you know, she's a 22-weeker and she wants to talk about termination, then yes, by all means, you can talk about termination, but still you need 2 clinicians to agree on it.
Yes. Does termination involve signing of 2 consultants? Another question.
Yeah, Sunanda is asking that if teenager keeps on insisting for termination due to bullying at school at 25 weeks, how do we convince her? Well, that will take your skill, Sunanda. That's again like, you know, how you try to counsel her, because at 25 weeks, legally, you're not allowed to terminate the pregnancy unless there are other concerns. So that will again take a lot of counseling. And you have to tell her that, yes, I do agree that this is a difficult time for you. And like Fatin mentioned very well in the station, that, you know, you have to talk about all the support services that are there and try and build that trust with her. Dr. Vandana is asking, can we inform the GP? Yes, you can.
You can. Yes. And somebody is asking that, do we need 2 signs from consultants for a termination?
We don't need 2 consultants, but we need 1 consultant and 1 can be the other doctor.
2 signs, I think. In the
Yes,
guideline, it is written 2 signs.
2 signs, yes.
Yes.
So 1 has to be from the consultant and the other 1 can be any doctor. But generally, like, you know, they always go for anybody above ST4 level.
Do we need to ask for reason?
What do you mean by reason, Shiraj?
Of late booking? Yes, you have to explore. In every station, you have to explore why she is coming late for the booking. Because ideally, the booking should be at or around 10 weeks, isn't it? We have to explore the reasons.
Yes, but in her case, like, it's pretty much obvious, Raj, that she is a teenager. By the way she was talking, you could tell. And she kept on saying, my midwife keeps forcing me. So, but still you need to, like Dr. Zaib mentioned, you need to explore that reason. Which I think Fatin did ask me as soon as she started, where I said that I wasn't planning on this pregnancy, but I've come to terms with it. So she did explore.
She's pregnant now. So how you can talk about contraception now? If it is unplanned, you can ask that, you know, were you on any form of contraception or not? Yeah. Even if it is unplanned, but now she is pregnant. So you have to deal with the pregnancy rather.
I think this would come, Siraj, pretty much in her postnatal period, where you have to talk to her about the safe sex practices that, or if you do get time in the station, and if you do want to, you know, make sure that you've completed everything in the station, you can say that I can understand, Anna, that this was an unplanned pregnancy, but, you know, for next time, just make sure that you adopt safe sex practices. But I would say not in this station particularly.
Exactly. Another question is very interesting. Boyfriend is in prison. Do we need to explore the reason why is he in prison and why she doesn't want to talk?
No. I wouldn't go ahead and talk about
Me
that.
Too. I wouldn't go ahead either. I won't go into, I mean, that much of detail to just, you know, lose my, you know, the time. So it's better just to be specific.
Because like she said that my boy, I don't speak to him, he's in prison. So that's enough for us. We don't need to explore anything about him. Unless like if there's a patient that is complicated, where say you're worrying about ABO incompatibility and stuff like that, that's completely different.
It could be the case of rape. Yes, it could be. And she is going to tell you, you know, that, I mean, it is unwanted pregnancy because I have been raped and, you know, I have filed a case and the things are moving forward and moving on, so then you can just say that okay, I got it, I understand, but don't still go into detail, much of the detail.
Yeah.
This is not your
Thank,
domain.
thank you, Zeb. Yes, Seema,
Yes.
I completely agree with Zeb.
Hmm.
This was a consensual intercourse that they had. So she said my boyfriend, but she didn't show you any signs of saying that it was forced on her.
Yeah, forced. But yes, in history you can even ask, okay, that was it a consensual sex, or or were you forced to have sex? Is it planned or unplanned? So unplanned, so her body language, pretty much is going to tell you, her body language, her tone, her expressions. So I don't think there is, a lot to talk, more of the boyfriend.
I think this
Partner.
station was just purely based on counseling and what all advice can you give to these girls, because they are very, very high risk, as in like they're very vulnerable. So you have to kind of reassure them and build that trust with them, which I think Fatin did when she
Yes.
kept on talking about the reassurance. She kept on talking about confidentiality. She kept on saying that, I am willing to help you in every way. So I think this is what this station was all about. So I think she picked up really well on the clue that was given on the patient task, that it's all about counseling and the advice that you need to give to this girl.
Okay, so there is another question, and then we will sum up this teenage pregnancy. Another candidate is asking that partner age is 42 and the sex is with her consent. Then safeguarding will be involved, and does it come
Yes.
under rape?
It doesn't come under rape, but yes,
Rape.
safeguarding will be
Yes.
will be involved in this.
If it is 42 and the girl's age is pretty, kind of young, 13, 14, then yes, then you have to explore more about rape. But if she is 21, 22, or if you can say the 18, 17, 18, 19, but still I think you can explore and you can just touch that part and leave. Don't dig too much.
If it's consensual, it will never be considered as rape here.
Rape
But
at all.
if
Yes.
it's about the age of the partner that you need to explore, because if the difference is more than 3 years, you have to always involve the social services.
Exactly. Okay, that's very good. So I think we had a pretty good, the discussion. Yes, another question.
Hello,
Hi,
Dr. Shefali, I have one question.
Yes.
Suppose this girl wants termination of pregnancy. That under what clause termination of pregnancy we can do?
I don't think that it would come under a social cause. And clearly, there's no fetal abnormality. So she wouldn't qualify for any of the clauses, unfortunately.
Yes.
And she's not giving you any signs that, her life is endangered. So it wouldn't even qualify for any clause B or clause A.
Yes.
So that's why I told Fatin that termination of pregnancy in this station would be out of question.
Yes, thank you. Thank you, Dr. Shefali.
No worries.
Hi, Dr. Shefali. Can I ask one question, please?
Yes, go ahead.
Yeah. She asks about the sexually transmitted infection. So do you think that we can ask, and another thing that about the partner also, she has any other partner?
Yes, why not? You can.
Okay. Next question is that you told that for this pregnancy, not this one, even though patient is came that no, I don't like this one, it will affect my mental health, and I cannot tolerate this, I cannot manage my study and everything. So maybe she will be affected mentally. So according to the clause C, so we can put it if it is more than 24 weeks and she is mentally affected, so we can put it clause C. Am I right?
Clause C is more for social concerns, right?
Social concerns.
Yeah, social conscious means she's you know, she cannot look after
So,
baby, and not this case. If she will
yeah,
come that no, I cannot look after this baby and I have lots of problem, uh, I cannot manage. So it will affect her quality of life, even though mentally she will be ill also. So lots of problems.
I
So at
think
the
you're
time we
right in
can.
asking this question, but what I will say is that once they're over 24 weeks, it becomes quite tricky because it's not just on you that we can go ahead and explore this. First of all, she will have to be, kind of netted by the psych team as well. So anybody can come and say that, oh, I don't think I can cope with it. So you can't just go ahead and offer termination to everybody. You will have to, in that case, it will be a multidisciplinary team that we'll have to start talking about. Then it will be decided by the consultant psychiatrist. You'll have to involve a lot of people and kind of, kind of section her and see if she's under section, that's completely different.
Yeah. No, of course we have to involve the multidisciplinary
Yes,
team, but
yes. So
C and D, it is more than 24, the clause
24.
C and D. Yeah.
D, as far as I'm aware, is up to 24 weeks.
Yeah, other all are up to 24 weeks, but that was less than 24. But C and D only more than 24 weeks. What I know.
C and D less than 24 weeks.
C and D.
Yes.
All right, maybe I'm telling. I'm sorry,
Not more.
I'm telling the opposite.
No, that's completely
Yeah,
because you can.
opposite. Yeah, sorry. Yeah,
I
yeah,
just thought
opposite.
that no, I'm not aware of that because it has to be less than or up to 24 weeks. That would
Yeah,
be
just I told the other way around. Sorry. Yeah,
that's
yeah,
fine.
less than, yeah. Sorry.
Any more
Thanks.
questions? Right. I think we're ready to go ahead with the next station, Dr. Zeb. I'm still happy to keep on answering the questions on teenage pregnancy. You can type on the chat box and I'll keep answering.
Yes, yes. Sorry, I got a call from hospital. Okay, yes. Uh, exactly. So who wants to come for next station? So thank you so much, Shefali, and everybody for the valuable discussion on teenage pregnancy. I think we have never done this station before, so I think this was a good rehearsal. Okay,
Can I
Rana.
try?
Okay. Yes, yes. Who is there?
It's Purnima here.
Okay, Purnima. Yes, you can. Okay, all right. So let me show you the slide with the question and then we will go about. Take your 2 minutes time, okay? All right, start. Do you want to come online? So at least you will be aware of the expressions and I will be seeing your expressions as well.
I think I have started my video. Can you see me?
Yes, I can. Vandana, I can see you. Okay, fine. That's great.
Sorry, but I can't see you. I don't know.
Just focus on station.
Okay.
And I will come. You ready, Vandana?
Okay.
Okay, fine. Start.
Hello, hi. I'm Dr. Purnima Dalal here. May I check your name and age, please?
Yes, I'm Amanda Matthew and I'm 35 years.
And what would you like me to call you?
Amanda is fine, doctor.
Okay, Amanda, please call me Purnima. I gather that we have seen you before in the clinic and had taken a biopsy, and you are here to get the results. Is that right?
Yes, doctor.
Okay. Amanda, are you on your own today, or is there somebody with you?
No, I'm on my own today, doctor.
Okay. So as I'm seeing you for first time, is it okay if I ask you a few questions to know a bit more about you?
Yes, sure.
And then we can discuss the report?
Yes, sure.
Okay, Amanda. So you have been having some problems with itching, I gather, for which we did the biopsy. Can you please tell me since how long it has been going on?
Actually, I had that, the kind of itching for quite long. And, when I visited the clinic and they said that it's better that, they think that this is not good, this is kind of suspicious. So they wanted to just take the biopsy. So they took biopsy and, they said that, they will call me up once the biopsy result is there. So today I'm here to discuss the biopsy result.
Yes. Do you want to know the result now, or are you okay if I ask you a few more questions?
Anything would do, doctor. Anything.
Oh, okay. I know that you are on certain medications because you had a kidney transplant before.
Yes.
How are you getting along with that? Any problems?
No, so far I'm okay. I'm doing well, and
Mhm.
I have to live with this transplant. So I know, what exactly the problem is, and how I have to cope with this transplant. So yes, I'm
Mhm.
living with it.
You're living with it, okay. And whom do you have at home for support?
Yeah, my husband and my kids.
Husband and kids. And how many children? You have got, I bet, 3 children.
Yes.
Yeah. Were they all delivered normally?
Yes, they were all born vaginally without any complications. I was okay even after that. And doctor, they were born, before I had my kidney transplant. So
Mhm.
luckily, I didn't face any kind of problem.
Okay. And have you got any allergies?
No, doctor.
Okay. So, do you suffer with any medical problems I need to know of?
I think this was enough. Transplant is enough.
Okay. And few lifestyle questions. Do you smoke or drink alcohol?
No, doctor. I do try to be very vigilant with regard to my health because I'm a
Mhm.
transplant patient. So, I know, how I have to do the things. So I do try to avoid, everything. Smoking, alcohol. Yes.
That's really great. So I can see you have tried to keep a control on how things are and so on. Okay, great. And would you know your weight to height ratio?
Yes, it's 26, doctor.
26. Okay. So coming back to your report, Amanda, I have checked it against your name and NHS number. It does belong to you. Now, I'm afraid I have got some concerning news for you.
Is it cancer, doctor?
It is not cancer, but it is something what we call as a precancerous.
uh, I had dealt with this, the kind of precancerous with my cervix as well. I had, one operation on my neck of the womb a few years ago. So I know what exactly is it. So this is not what I was hoping for. But yes, please go ahead and tell me what exactly it is.
I'm really sorry to meet you under these circumstances.
Yes, doctor.
Did you want to call somebody to be with you for support?
No, it's okay. It's okay. It's just I was not hoping for this news at all. So anyway, anyhow, I have to deal with it. So what's next, doctor? What I have to do further?
Yes, so so the biopsy report does say that it's at an early stage. So what it means is that if we were to leave it, then in few years' time, then it can turn into cancer. Okay, so it's not cancer at this point in time.
Okay, all right.
So what I'll have to do is from here on that we'll have to refer you to the specialist team of doctors, what we call as an MDT. So, and then there are certain tests which we need to now, I need to ask few more questions. I know that your smear has been normal and you did have a procedure for CIN before.
Yes, my last
Okay.
smear was normal, doctor.
Normal. Okay. So, so what we'll have to do is that we'll need to see you in the clinic with the specialist team of doctors, may need to organize some more investigations. Okay, because this particular condition can be associated with other associated problems, like CIN we already know of, but sometimes it can be linked to a problem in the back passage called as AIN. So you would be
is this because of that CIN what I had 3 years ago, the treatment? Is it because of that?
Not necessarily, but studies have shown that there can be some link associated with these conditions. It can happen. So it may be related. I can't be certain.
Okay. All right.
Yeah. Is there any question on your mind right now?
Doctor, I'm pretty much worried that, I mean, because I'm having this itching and burning on my, the vulval area. So can I give this to my husband, while having excess?
Yeah. Now, this is not something which can transmit from person to person. Now, I needed to ask. Previously, have you had any infections in the form of HPV?
Yes, I think I had, the many tests, plenty tests done, and I do go for the smear testing every year as well. So yes, they do take, this HPV, but my last smear was normal and it was, the negative. But I think earlier before that CIN3, I was positive. I know.
Yeah, that can happen. So it's not something which you can transmit it to your husband. Okay. Is there any other question you have on mind?
Doctor, what can be done now? Because already I am, I had operation, I had transplant. So what next? Do I have to go for surgery again?
So there are ways to manage this. So it depends on how deep it is. Sometimes if it is a very superficial, we can try and treat it. And most women, if identified early, the lesion can resolve on its own sometimes. Okay. So if we have to treat it, then we could treat it either in the form of applying some creams, what we call as an imicoid cream. So one can apply that, or there can be a treatment in the form of giving some light, like photodynamic treatment. But these all decisions will be taken by this team of specialists.
Which treatment by light, doctor?
It's, I think, the photodynamic treatment, but I'm not the specialist, so I will exactly take opinion from the MDT. Okay, and then give you the exact information. So I know going through all these investigations and treatments would be too much. So I would consider referring you to a counselor. Will that be okay for you?
Yes, that is fine. But doctor, I didn't get it. What is going to be the treatment option? Because I already had the LETs 3 years ago. I already had transplant. So what is going to be for this? Like you said that this needs to be treated as well.
Yeah. So so like I have said, what we could do is we could remove it. What we call as an excision. That is something which can be offered. Or I said that it can sometimes go on its own, and then I said there is a cream which one can apply to
so
try and
to remove the whole part down below.
No, we will remove only one side of it.
Okay.
On the edge.
Okay, that is pretty concerning. Oh my God, how would I look?
I'm sorry that it may be something which it all depends on how the MDT team decides. Means if you are trying to remove it, then the team would discuss with you the option of replacing the area with alternative tissue from your own body. But I think I need some more input from the team before I can guide you along those surgeries.
Okay.
Yeah. So I'll give you some information leaflets.
All right.
Yeah. And some link to the support groups. And you can have a read about it. And then I can organize another appointment where we can see with my consultant. And
Okay.
feel free to come with your husband if you wish, or any friend for support.
Okay. All
And
right.
if you any questions you have, you can feel free to write it down, and we will try and answer you next time.
Okay. All right. Thank you, doctor.
Is there anything on your mind which you want to ask?
So many things. But now I will ask as an examiner.
God,
Why
sorry, I was
did
not
you
prepared.
messed up in management, Purnima? You were going so good in history, but you messed up in management.
Oh.
Okay, okay. Now, just be relaxed and just tell me what is the management of VIN, sweetheart?
Miss, what we do is, Miss, I haven't read on the topic. I'm just telling from my part to memory.
Yes, whatever you remember, just tell me. What exactly do we do in VIN? What is VIN? The area
So
was
vulval
biopsied.
vulval
The area
intraapical
was
neoplasia, yeah.
exactly. Okay, so whenever you are going to break, you know, the diagnosis to somebody, first of all, you have to take the name of that diagnosis. Okay, so what I
Okay.
can see from your biopsy is that you are having a condition called as vulval intraepithelial neoplasia. Have you ever heard about it? Okay,
Okay.
so always, because these kind of stations are two-way station. You have to go step, you know, the side by side and step by step. Okay, so if she says that, okay, CIN I had 3 years ago, but I have never heard about this VIN, but I remember, I can recall something from my, you know, the previous consultation, the doctor was worried about it. So this time it is vulva.
Mm-hmm.
Okay, so
Mm-hmm.
yes, you can say that, yes, unfortunately the report is, you know, the saying that, you know, you are having VIN.
Did
Okay,
I not say that exactly?
no, you
Oh
said
my
that
God.
it is a condition early stage,
Oh my God. Okay, I didn't
early
even
stage
realize I
of
didn't say
cancer.
it. Okay.
Okay, always remember, like, I mean,
Yeah.
whenever you have to break the diagnosis, first you have to say the exact name. Okay,
Mm-hmm.
because this way, first of all, you want to check the background knowledge, and then you are going to talk about the explanation in a very layman languages. Okay, but I think, you know, you got fumbled in the you know, the management, and regarding HPV, you knew that this already almost more than half of the information was in the case. Okay, she is on immunosuppressive, she is a transplant case, she already had CIN3 last year. Okay, that's procedure, and because of the transplant, we have to go and we have to do the annual smear testing. Okay, and the last
Yes.
smear is normal, so that is
Mm.
pretty good, pretty reassuring for her, that we can at least tell her that, okay, this time, okay, so don't be like, I mean, kind of judgmental, that, okay, this is because of the CIN, now you got the VIN, and next time you are going to have the, you know, the anal or whatsoever. So not in so many words. So at least you have to be, you know, don't ask directly that, have you had, you know, the HPV infection? We know that CIN is because of HPV. That's why she had, you
Okay.
know, the CIN3 treatment. So rather, you know, you can ask about, like, I mean, and you didn't address her, you know, the Marina as well. Marina was in situ and she is amenorrheic. Okay,
Mm-hmm.
so don't unnecessarily, you know, kind of I think you didn't ask about periods, that was good, but even if you miss something, okay, so you can say that, I can see that, you know, you are having Marina in situ and you don't bleed anymore, and apart from that, you know, I can also see that your smears are normal, and you know, the last smear was up to date and normal as well, that is pretty good, but your biopsy report says that you are having VIN. So if I tell you now that VIN, so now how you are going to explain about VIN? So you can just say that, you know, this is vulval intraepithelial neoplasia. Okay,
Mm-hmm.
so vulva is the area which is around the vagina, which is surrounding the vagina, that is totally, you know, the part is called, termed as vulva, and intraepithelial means that the cells are there. Okay, but it is, you know, the into the epithelium. Okay, the condition which is or limited to the skin of the vulva. Okay, then you can say that, you know, the intraepithelial neoplasia, you can say that, okay, it can be the precancerous as well, because they are abnormal accumulation of the cells. So what you can do is that, but I can assure you that at the moment it is not cancer, but, you know, if it left untreated, it can convert into cancer with the passage of time. Okay, or you can say that, however, 1 in 7, 1 in 6 women can develop cancer with the passage of time if it is left untreated. Okay, so you can speak like this. So definitely she will be upset, because she already had, you know, the CIN3, and now she is having VIN. So then you can be a bit, the kind of, the more kind of, the can of, you can say, like, I mean, kind of sympathetic at that time. I understand that, this is, very hard time that you have to, deal with this problem as well. But look, Amanda, we have to treat it, because we cannot leave you untreated. Because what can happen is, then you have to talk about the causes of the VIN as well. What you can see in her history, Purnima, what are the risk factors in history?
She's on immunosuppressants
Very
and
good.
she
She's
had
on
CIN before.
he had CIN before. Okay, then you can talk about, and you can touch, the more, some of the other precancerous lesion that can lead to VI. Yes, lichen sclerosis. You can say that it cannot be. I cannot 100% say that what could be the cause, but moreover, the many women can develop the CIN if somebody is on long-term immunosuppression therapy, by which immune system is not, that well, the controlled. So by that way, the virus is not pretty much cleared, because it is because of the HPV as well. So virus is not cleared because of the immunosuppressant therapy, and it can be associated with CIN3, and the culprit is same, the HPV as well. Okay. So yes, and it can be because of the smoking, but luckily you don't smoke at all, so this is very good part. And it can be in the background setting of some other vulval conditions like lichen sclerosis, lichen planus, but and this is not the usual condition in your part. So the treatment management options we can offer you is that we will be dealing you with the help of the multidisciplinary team approach, where group of the specialists will be dealing your case. And the treatment option what you can offer, number one is wide local excision. Okay, you directly said that we will remove the side of the the vulva, and for the treatment you directly said that the photodynamic treatment. Okay, even if you don't remember something, don't just try to bring something which is bit unusual. Okay, photodynamic is a part, but it is still in the trial. So what is the main the stay of the treatment for VIN? That is the WLE, wide local excision. Okay, so you can say the wide local excision can be done, that affected area of where this VIN is, that we will be removing that. Okay, and if then if the team they decides that we have to remove the part of the vulva as well, then we may need to take help from the the plastic surgeon as well. Or you can say that we will be doing the skin grafting, just because she will be upset, everybody will be upset. The vulva is a thing where you need to be very careful in your the kind of counseling and the management, because you are going to talk about that how this figure she will be if we are removing somebody's vulva cosmetically. She will be upset that that I am going to be very upset. How will I look if you are removing my the one side of the vulva, obviously. Okay, so then we have said that HPV can be there, smoking can be there, immunosuppression, lichen sclerosis, lichen planus can be there. Okay, so then you can say that we do have couple of options, but not all options are suitable for the every woman. Okay, so we will be talking about I will be giving you an overview, but what can be the options for you. But certainly the management team will be deciding you about the perfect option for you. So wide local excision, skinning vulvectomy. So you can say that you will usually be having affected piece of the skin removed by the surgery. Mostly small areas can be removed without any problem. But if a large area to be removed, so don't just talk about that we will remove half of the vulva or part of the vulva or complete vulva. Okay, this will clearly upset the woman who is already going through a lot. Okay, so you can say that if large area to be removed, then you may have some plastic surgery to prevent from excessive scarring, skin tensions, and the problem having sex as well. And in this case we can take some kind of skin graft. That skin can be taken from other side of the body, and that can be made, if at all it is needed, it can be done. Then you can say the laser ablation. Then you can say that that can be the option in which that particular affected area can be destroyed by the laser or the tiny electrical currents. Okay, we call it as ablation. Then there can be, if she says that okay, is there not any the kind of ointment or the treatment option in the form of medication, you can say yes, up to my knowledge I know that there can be the topical treatment where we can apply the imicumod treatment. That is also the very kind of immune modulator treatment that is going to work at the cellular level, and that is going to heal. But at present I'm not 100% sure, or I'm not cannot give you the guarantee that how well it can work in your case. okay, since you already on immunosuppressant therapy. But usually, these type of ointments can be used for the several weeks, and the response can be slow, and the response can be taken, and it can also be the alternative to the surgery or even after surgery as well. Are you with me, Amanda? Yes, I am. Okay, so I think these can be the options which the group of the experts can offer you. Okay, but they will be in better the position to guide you and to tell you that how they are going to offer you according to your condition. Okay, so then you can say that you will close the station, you will invite the questions later on, because you have to complete the loop in every simulated patient task, right? So you can say that after treatment you will be having the continuous or the careful follow-up, like every 6 to 12 months, and usually it is recommended for like 5 years, and if it is after surgery, because we can see that sometimes it can recur. Okay, so she can ask you that can it spread to the rest of the body, can it turn into cancer? So you can say that yes, it can, because the culprit is main, or you can say the main culprit is HPV, so it can affect the changes in the neck of the womb, the area around the vagina, area around the back passage as well. So, and also the more if it is left untreated, or the diagnosed in the late stages, so it can turn into cancer as well. So it is important for you to have regular cervical smear check annually. This you have to say at all times. Okay, you have to stress on this importance, because the regular cervical smear annually are very much important. All right, so you will say, you will close, I will write the summary of our discussion and your plan in your notes, and I will also give you the copy, and I will send a copy to your GP as well. I will give you some helpful leaflet about VIN management, and also website link patientinfo.uk, and contact number of support groups as well. Okay, so all right, this way you will close, you will send the patient for the the MDT, or you will connect her to your next follow-up appointment with your consultant in the vulval clinic, whatever you want to say. Okay, so this is how you are going to deal with this patient, Purnima. Okay,
I was
clear?
thinking this because it was VIN, because the wide local oxygen, is that the first line? I mean,
Yes, it
I don't
is.
know.
It is.
I thought in the BASH guideline there were some other options, and wide local oxygen is also there. And because she was immunosuppressed, I thought I will leave the decision for the MDT to do it.
No, yes, ultimately we will leave the decision to MDT, but at least you have to speak something, or you will just say, okay, you have VIN, okay, go to MDT. We cannot do that, right? At least we have to say something about treatment options, that okay, these can be the options, and yes, the MDT is going to be in better position to decide according to your the condition basic. Okay,
Okay. So VIN and treatment for vulval cancer both kind of be the wide local excision then
yes.
straight away. Okay, because I would have said all the thing what you mentioned for
Vulva is
vulval
kind of
cancer. Yeah, because of plastic surgeon, sexual dysfunction, and all that I would have said. So okay.
No. Sexual dysfunction is okay, because in vulval cases, what you have to do is, okay, this was VIN, okay, pretty straightforward case, because we know the treatment options are there. But if it is because of the, the itching all the time, there are 2-3 cases in the, the last, the few years, what we do see. There is one case, this is a lady who is coming with, the repeated vulval itching and the burning, and she is applying over the counter steroid cream as well, Dermovate, to be very specific, it was given, and it is not getting better. So what you will do in that case? Okay, so yes, we have to explore in that case, the all causes of vulval itching and vaginal itching as well. Okay, so if something is not getting better, so it's not like that, the steroid is the treatment option for, the every discharge there is. Okay, yes, in the case of the vulval lesions, ultra potent steroids are the treatment options. Okay, in the lichen sclerosis, in lichen planus, and in the other cases as well. All right, so this way you have to speak. And then, my dear all, remember this thing for the vulva. In the vulva setting, if you are dealing with benign lesions, okay, always divide your management into 2 options. Okay, one is general advice, that should be general vulval care. That is very much important. And then specific treatment. This, the kind of station is incomplete if you don't touch vulval hygiene or vulval care. Okay, that don't use soaps, don't use the emollients. Okay, and don't take the kind of, don't apply the talcum powder as well. Talcum powder used somewhere, I think in RCOG course in 2017 there was a case that was being discussed. Okay, so yes, the talcum powder use, you don't have to use talcum powder as well, because talc can be, the some kind of, the harmful for the vulva as well. So you can, speak about vulval hygiene in all cases of itching of the vulva. Okay. Moreover, for the lichen sclerosis, lichen planus, you have to be very specific. Okay. All right. Okay. Clear, Purnima?
Thank you. Thank you.
Okay. Okay, sweetheart. Clear to all of you? Any other question? Previous
Yes,
slide? Okay.
Dr. Zaib,
Yes.
Dr. Zaib, okay, you'll explain now everything, isn't it? So after
Yes.
listening, then I can tell. Okay, no problem.
Okay, okay.
Yeah, thanks.
Fine, fine. I hope you are going for exam, Salma, is it?
Yes, Dr. Zaib, very nice.
Okay, all the best, sweetheart. You will do good, okay? Just stay confident, okay? You know very good. You know, I think many things, but in a good way as well, okay?
Thank you very
So,
much.
for the vulval lesion, divide your management into two parts, okay? Conservative, or you can say the vulval care, and then specific in terms of, the medication. This is for lichen sclerosis, lichen planus, okay? And yes, do, the learn about that, how to apply that, the ultra potent steroid. That is very much important, because lichen sclerosis, I still can recall that it was once a structured discussion, once it was in the form of simulated patient task as well. For her symptoms, no, you cannot offer anything, okay? You will send her to MDT. This is VIN, okay? This is VIN, so you're not going to wait, you're not going to do anything, okay? You will send. Burning and itching, no. Burning and itching is because of VIN. So what is going to be the treatment? You can just give symptomatic treatment if you think that, you can give, the symptomatic treatment. That's it. But I don't think you can offer any steroid to VIN at the moment. Okay. Okay. Great. Shefali, any other input for this station?
No, I think you've pretty much explained everything, Zeb.
But I thought if something is missing, so we can give, that thing to the
Yeah, but
candidate
I'm
as
more
well.
than happy to take any questions.
Yes, yes,
But I think
exactly.
you've summarized it really well.
Dr. Zeb,
Yes.
you asked like the question of HPV, can HPV be transmitted from me to my husband? Like, can you give us a model answer whenever we are speaking
No,
about?
this is not HPV, sweetheart. You got me wrong. Okay, I asked a question because I'm having itching because of this PIN. So can I give this, the itching to my husband? That was the question. Okay, HPV is
Okay.
sexually transmitted. HPV is
Yeah.
sexually transmitted.
Suppose
don't.
she
Uh-huh.
knows that it is an HPV infection and it is caused by HPV infection. In many stations, they ask that
I
how
got your.
did we get? Yeah,
I got
can
your
you give us
point.
a model answer?
Okay. For HPV, usually, we can say that, okay, yes, HPV is the, infection, which is sexually transmitted, which is, the contracted by the sexual contact. And, this is a good question, in fact, because there is a station for this, the cervical screening for the abnormal cytology of the cervix. Okay. In that, role
Yeah.
player can ask you that, is it my boyfriend who is giving me this infection?
Yeah.
Because she has had multiple sex partners in the past as well. So you can say in that case, okay, look, this is very hard to say that, which of the, sexual contact has given you this HPV, because HPV is very slow growing, the organism. It just sits in the cells in the neck of the womb. And sometimes, it doesn't get noticed easily, because most of the time, if the women are healthy, if they're not having any conditions, so 80% of the cases the virus will be cleared off from the body. Okay. And usually every sexual woman can have this virus at, a one time in their life, but usually it goes unnoticed, because our body's immune system, clears it off. But sometimes it rarely, the sits in the neck of the womb, and then it can cause problem. Okay. And there are, the certain strains of the virus, there are hundreds of the HPV types, but usually the types which affects the, the neck of the womb is 16 and 18. That is a bit dangerous. And sometimes we do see that, the 16 and 18 in the many of the lesions of the neck of the womb. Okay, so you can say for the HPV that we cannot clearly say that which of the boyfriend, number one, number two has given you, because it goes very slowly. It is going to make the changes in the neck of the womb with the passage of time. It's not like that today you have got the infection and tomorrow you will get the disease, because it takes time to get the disease and to have the changes as well. That's why we are doing, the regular cervical smear. Okay, every 3 years or every 5 years, you can say. So this way again, you are going to stress on, the screening.
Screening.
So this way, yes, that you have to stress. So you can say, and you can, beautify your, the sentences in that way, is that, that's why we do screen every woman in the UK at NHS as well, because, we really are very concerned about, the women's health, that we do want to see that, which of the, the woman is getting affected by this, because it takes time to be, and to the cause the problem.
Yes.
Show the
Yes.
change.
Thank you.
Okay.
Thank you so much.
Okay. That's great. Any other question? Any other question, guys?
Yes, Dr. Zaib, one
Mhm.
question, please.
Mhm.
Dr. Zaib, which one you explained that for the imucumate and the laser therapy. So
Mhm.
what is the side effect of this laser therapy, complication and side effect, we can say?
Laser therapy, if you really want to talk about, so you can say, the kind of disfigurement of the vulva, you can say there can be some kind of burning of the vulva. So, I mean, that can be still, if you don't know, you can say, in few words like this. For the imucumode, it is immune modulator, it is very strong therapy. So for the side effects, again, I'm sorry, I'm not very clear that how you are going to talk about the side effects per se. But yes, you have to talk about their, the application, because that needs to be, applied on the daily basis for longer period of time, because it will take time to act on your, the immunocompromised cells as well. Okay, so this way I think you can say. And for the vulva, the side effects mostly are again the same. The disfigurement of the vulva, again itching, superimposed infection if it is healing. So I mean, all together, the vulva can be summed up like this, because the vulva is kind of, the thing where if you take one disease, so the ultra potent steroid is going to be the treatment option for almost lichen planus, lichen sclerosis. Okay, so all these, the things.
Imucumate
So
also,
Mhm.
imucumate also causing burning, is it right?
Yes, it
Imucumate
does
also.
cause, burning as well.
Yeah, thank you.
Yes.
Yeah, thank you very much.
Okay, great. So I think we had a pretty good discussion on these two cases, but still, if you guys have any question, we are open to take any question. And all the best to all candidates who are going for, the exam this November.
Thank you very much, Dr. Zaib, for your excellent session today. And
Welcome,
thank you, Dr.
sweetheart.
Shefali, also. Pray
Oh,
for
you're
us.
most welcome, Salma. All the really best for your exam. I'm sure
Yes,
you're going to do wonders.
she's a
Thank you
very
very
good
much.
candidate. I know her. She's very good candidate, and inshallah she will do good. Okay, so all you have to do is be confident, and don't be overconfident. Just be like, kind of calm and a good candidate. Okay, all of you, please. Okay, that's very great. That's
One
very great.
advice I
Thank you
would
so
give
much.
Salman, since you're going for the exam, always listen to what the role player is saying. I think
Exactly.
Dr. Zeb has emphasized a lot of time, and
Yes.
I cannot back her up in this enough. They will help you. Trust me. They really want you to get that point. So if
Exactly.
keep on asking the same question, don't get intimidated by them and think that, oh,
Hmm.
why is she asking me this question
Hmm.
again?
Hmm. Hmm.
That's
Hmm.
because that question is carrying marks. So
Exactly.
that's why she's asking you. So just,
Exactly.
active listening.
Active listening is very much important. And please, for the structured discussion, everybody, please, everybody, be extremely vigilant and be, ready to take questions. Okay, because it will be written outside that you will be asked 4 or 5 questions. So please, don't just put your whole knowledge into question number one. Because as an examiner, really, I do struggle. Where do I have to give the marks to this candidate? Trust me, don't be like this. You have to be structured. Okay, so please stop after giving the few lines for the question number one, and the wait for next question at least, because in every question, unless it is only one question, and then examiner will be quiet. And that I have seen for the case of the ulcerative colitis, infliximab. In that case, that was my exam question. And the examiner asked me, okay, can you please summarize the case and give me the management, the plan for this lady. That's it. And then he kept quiet. And I had to speak for good 9 minutes. Good 9 minutes. Okay, so unless it is that, okay, summarize the case and then give me the management option, then you have to speak. But if it is like, kind of the evolving station, one after one, so please listen to the examiner as well. Give him time, give her time as well. Okay. All the best, everyone. Thank you so much
Dr.
for the
Zaib,
appreciation.
Dr. Zaib, last question, please.
Mm-hmm.
In your case, this one, so what you will advise for history, limited history, that to ask this case? What you will advise?
Which case? Which case?
This one, BIN. So what you will tell that limited history, that this you have to ask.
See, look, in terms of, she's here to discuss about her biopsy result, right? So you have to be focused, first of all. Almost everything is given. Her name is there. She's 35 years. She's para-3, all vaginally born. So you have to skip, the obstetrical, the history as well. You have to skip, this Mirena. But you have to emphasize on that. You can say that I can see that you are having Mirena. So any irregular bleeding so far. So she will tell you that no. Okay, that although it is written that she has no periods, but you can just touch and you can just leave. Okay, don't just drag on. Okay, how many periods? Do you ever bleed between 2 periods? Okay, heavy period. She's not having periods. Okay, so you will not drag this gynecological history. Then she is on yearly smears. Okay, you know this. She had LETs in the past surgical history. She had LETs. So how you can ask in the surgical history is that any other history, any other surgery than LETs on you, especially on the the down below. So she will give you any hint if she has had, or apart from this transplant and the legs. So she will tell you last smear was normal. Okay, now the biopsy is telling us the VIN. So you can take the history further. You can just ask about allergy. You can just ask about other medical issues, because if she is on immunosuppressive medication, so we know that they can raise the blood sugar levels. So patient can be on some kind of the pre-diabetic or diabetic, or if she is on steroids, then at least you have to ask. Okay, so in that case you can ask about any other the medical illness, apart from you are seeing your GP for any other thing. And when was your last check? Everything, allergy, that's it. Okay, smoking, alcohol, you will ask.
انا دايره ايس كريم
Hello, yes.
مصاصه بزازه بزازه حلوه تراي.
Oh, excuse me. Okay. Anyway, so Salman, is it clear to you?
Yes, thank you very much. And you told that follow-up will be six months for 2 years.
It is going to be long-term follow-up. It goes long, years, for years. Roughly, we can say that it can be 5 years, every 6 months to 1 year. Because you will call the woman, you will talk about the sign and symptoms. You will talk about any new sign and symptoms. Okay, because you have to be aware of the cancer as well. Because you need to see the lesion as well. Are there any kind of changes in the skin?
I think if I can add on to that, Salma,
yes, please,
I think initially for WIN, we always tend to follow them up 6 monthly for first 2 years, and then they go yearly follow-ups. So we never discharge them. We keep on asking, like Dr. Zaib mentioned, about any new symptoms, because at the end of the day, there is that background risk of these cells converting into cancerous cells. So you can't really discharge them, but you can still go on to yearly follow-ups then.
Yeah. And Dr. Shefali, for your case, what do you think the history, limited history, please, that teenage pregnancy?
I think pretty much what Fatin did ask me, Salma. So
is it okay?
Yeah, I think she was bang on. I don't think that she went too much into the detail because my station was more about counseling. So she came to that point straight away, which I think gave her like points in everything. So like Dr. Zeb mentioned, just read the stations, the information that is already there. You don't need to waste your time on it.
Yeah. Yes.
And one last the thing I would say, and then I will close the meeting today. The first thing, not in this case, but as a whole, okay, You will not enter into the cubicle and you will say, I have your GP letter that is telling me that you are a case of the type 2 diabetes mellitus and you are diagnosed for the last 13 years and now you are on this, and now you are, don't, just narrate that. Okay. Don't just narrate the question. With the passage of time in the consultation, you can just pick important information from, because the case is going to be in front of you at all times. Okay. So I was telling that, okay, I can see that, you are having myelina as well. So apart from that, do you ever bleed, unusual bleed down below? No? Okay, that's good. Okay. So this way you can, extract the information from the question and then you can bring into your history or the management. Okay. Please, in the start, don't just try to give the central idea of the question, whatever is given out, because it takes a lot of time. It takes almost good 1 minute and 30 seconds. Even if you just rehearse with yourself, you will find, okay, you will see yourself that you are losing initial 1 minute and 30 seconds. Like Dr. Shefali said, that your history should be very focused and it should not be, I would say it should not be more than 3 or 3.5 minutes. Because in the next 5 minutes you have to manage the case, and in the last 1 minute or 30 seconds you have to complete the loop. You have to invite question, you have to give her PIL, you have to give her support group contacts and all. Okay, so be extremely vigilant. Okay.
Thank you very much. It will be very helpful for us. Thank you very much.
Yes. Okay. Don't just narrate the question inside. Just think, what exactly the question is and how you are going to start, and then just, go on with the case. Okay. All right. Thank you so much for the wonderful participation, everyone. Thank you so much, Shefali, for being with me. It was so good.
Thank you very much, Dr. Zaib, for a wonderful session.
Thank you.
And
Thank you
I
so
just
much.
wish all the best to everyone.
Yes.
Thank you.
Thank you so much, Dr. Zaib and Dr. Shefali, for this wonderful and informative session. I would also like to thank all the participants who have participated and joined us today. This side, Asma Amjad from the backend team of MedExam Expert. I'm here to guide you about our MRCOG 3 course. We're going to start our course from November 15, and the duration of this course will be 3.5 months. We are having 4 expert mentors to guide you. We are having Dr. Pooja Sharma, Dr. Zaib Qureshi, Dr. Alina Shirazi, and Dr. Mohammed Hassan. Now let me give you a brief introduction about our course mentors. So Dr. Pooja Sharma is our senior mentor for MRCOG 3 courses. She is working in NU at Singapore, and also she is the author of 3 books.
Yes.
Dr. Zaib Qureshi is our senior tutor for MRCOG, MRCPI, MRCOG, FCPS courses. Also, she is our COG examiner that you all are familiar with. Now, let me tell you about Dr. Alina Shirazi. She is also a well-qualified tutor for MRCOG, FCPS, MRCOG, MRCPI courses. She is currently working in NHS. Dr. Mohammed Hassan is our senior lecturer and tutor for MRCOG and MRCOG exams. He is clinical examiner for MRCOG 3 exams. Now let me tell you about the features that we are offering. There will be live sessions. You will get to practice a great number of homework tasks.
Dr. Shefali.
Yeah.
Yes, Dr. Shefali.
I'm completely okay with it. Don't worry.
No. Dr. Shefali. Okay, let me introduce Dr. Shefali. Dr. Shefali is MRCOG as well. Okay, she is working at NHS and she is a mentor of MRCOG over there as well. She is working with, I think college tutor, if I'm not wrong, right? Because she is giving, the plenty of workshops and plenty of, the on-sites, the sessions for the aspiring candidates for MRCOG Part 3. Okay.
Oh, thanks, Zeb. But don't worry, Asma. I'll take this one.
We are not going to spare Asma now.
Thank you so much, Dr. Zeb, for the introduction.
Yes.
So now let me tell you about the features. We are offering live sessions, we are offering a home task, and we will also be giving the feedback from our expert mentors. You will be exposed to more than 100 tasks altogether. All the difficult topics will be mentored. You will be added to a separate study group. There will be 24/7 Telegram assistance. We will give you access of extensive collection of study materials and the session recordings. Focused mentorship will be provided. We will also give you all the books, and there will be on-camera sessions. So here is a gift for all the participants who are listening to us today. We are offering 30% off on active and listener participant. To get the discount, you have to apply the coupon code that is active30. With this, the course fee that is $778 will be changed to only $544. Now here are the feedbacks from our beloved students of our previous batch.
And I was so overwhelmed after this feedback. Thank you so much, everybody. I can see some of the candidates are here with us today as well. So they have been so generous. Thank you so much, everyone.
So we are taking only limited seats. So what are you waiting for? Register yourselves. So now how you can register for the course? First of all, you have to sign up to our website. After signing up, you have to click on course catalog, where you will see multiple courses. Then you have to select MRCOG 3 full payment for February attempt. After this, you have to click on get this course. Then you have to apply the coupon code to get the discount.
Sam, and for the FAB candidate, please start over. Okay, time is not that much. FAB is just like 3 months away. Okay, so all the very best. See you some other time. Bye bye. Good night.
Right. Thank you very much again. Bye.